We don't talk about brain death as often as we should, actually. And amongst our colleagues, that's what we were discussing with Mrs. Despoti. Most of the brain death diagnosis is done in the intensive care unit of the Nicosia General Hospital. It's done in other intensive cares, of course, around the island, but we do the majority of the testing. And it's very important to raise awareness on the subject. It's an old subject, but it has a lot of controversy around it, both socially, culturally, and also religious controversy. So it's quite important that all new colleagues are aware about this concept. Just an overview of the presentation. I will be defining neurological death. We don't call it brain death anymore. I just called it for the presentation. It's called death using neurological criteria. That's the proper name of brain death. And we will talk about the variability in the definitions, how we determine brain death, and how we do the diagnosis. So diagnosis has a lot of confounders, a lot of prerequisites. We have to abide with Cypriot legislation and guidelines. We have minimal criteria, and then of course the clinical testing, that is the brainstem testing, the brainstem reflexes, and the apnea testing. I will talk just a few points about the ancillary tests and also some red flags in the testing. At the end, I will just say a couple of things regarding religious and cultural aspects. So what is death? How would you define death? When I was first asked this question, I thought it was a really trivial question. I thought, well, what is death? You cease to be alive. But then someone would have to define life. What is life? There's actually quite a few definitions in the dictionaries, and it's a quite controversial subject also. It's quite difficult to define death. The Britannica.com defines it as the cessation of life processes that occurs in all living organisms. The dictionary.com, I believe, says it's the irreversible cessation of biological functions, whereas the Oxford Dictionary defines it as the permanent ending of vital processes. Historically, death has been defined medically as when the cessation of having a heartbeat and lung function. So it's a triad between the heart, the lung, and the brain. The heart stops, the lung does not function, and the brain stops having any activity. Or the opposite, the lung stops, the heart fails, and then the brain ceases to be, so to say. But with medical advancement came the neurological death. So the heart, we can support it now with inotropes, with ECLS, with CPR. The lungs, mechanical ventilation, extracorporeal membrane oxygenation. But what they saw in the 1950s, in the late 1950s, and they described it as coma dépassé, which means a state beyond coma, a reversible coma. The persons were not waking up, the patients were not waking up. They described this coma then in Harvard criteria as brain death. And then we had the legal, medical, and social construct of brain death. It's not only a medical term, it's a legal term, the term brain death, and it also has to do with governance. So it's not only part of the medical society, it's also a legal concept, because when you declare someone dead, you register them as dead, and they are legally dead, and according to the government also. So brain death was equated, is the same as cardiovascular death. So he is dead as a whole. It doesn't matter if the heart is beating, it doesn't matter if you are giving oxygenation to the lungs, the person is declared dead. It's not related to transplantation, it has nothing to do with it actually, because it was long before the dead donor rule. It had nothing to do with the transplant process, but with the evolving of medical technology. So the American Medical Association and the American Bar Association, they defined death in medical terms as the cessation of all functions of the brain. And here just note the wording entire brain, and also the cessation, the cardiovascular death, the cessation of circulatory and respiratory function. And this was done in the Uniform Determination of Death Act in 1981. Since then, there has been a great transatlantic debate regarding brain death. So the Brits and the Europeans and the Canadians, we regard death of as the brainstem function, so the irreversible cessation of the brainstem, whereas the Americans, they regard the entire brain, including the brainstem. They don't only look at the brainstem. You see in both terminology the word irreversible. You will see this again and again and again, irreversible, permanent, irreversible, permanent. There is nothing you can do to change it. The Brits say that you need to have an event, either intracranial or extracranial phenomena that causes this clinical state that is diagnosed by a medical professional. The Americans, they talk more about what happens with this state. So you need a coma, a loss of consciousness, a lack of brainstem reflexes, and a loss of breathing. Just a little note here on what the entire brain means and what the brainstem means. The brainstem is the infratentorial region. Its function is, all vital functions pass through the brainstem as well as consciousness, whereas the higher brain regards the bilateral hemisphere and its regard for consciousness and cognition. I cannot stress this article enough. It's a very important work published in JAMA in 2020, the World Brain Death Project, the determination of brain death, death by neurological criteria. And what does this article say? It says it's not important. It's not important if you talk about the entire brain or you talk about the brainstem. You need these three criteria, and if you have these three criteria, you have a brain dead person. So you have a coma that is unresponsive. You know the etiology. You didn't just find someone on the street in a comatose state and you said they're brain dead. You know he has known etiology for the coma. You exclude all reversible causes and confounders, and you do not have brainstem reflexes, and you do not have the capacity to breathe. Why do we focus on the capacity to breathe? Everyone knows the heart works on its own. So it doesn't need any innervation from the brain. But the lungs need active innervation from the brain. They depend on it. And that's why we always talk about the capacity to breathe. And this is what we do in the hospital. So we identify the pathology of a potential brain dead person. He's in a comatose state with a known etiology. Any increase in intracranial pressure and decrease in cerebral perfusion pressure, the cerebral perfusion pressure is the mean arterial pressure subtracted by the ICP, causes a loss of blood flow to the brain. And this state needs to be known. I have to be certain. At any time, if I have any doubt, I do not undertake clinical tests. I exclude all potential reversible causes of coma. And then I perform my clinical exam, my apnea, and if I require any ancillary testing, I proceed to the ancillary testing, I document everything, and I declare the person as dead. Some intracranial causes of brain damage. The most common one we see in the hospital is traumatic brain injury, so after a motor accident. Hemorrhagic stroke is often ischemic stroke. We have seen young patients with infectious diseases of the brain, mostly meningitis, neoplasms, obstructive hydrocephalus, and as you can imagine, the most common cause, extracranial cause, is global anoxic brain injury after resuscitation. We see this quite often, actually, so after cardiopulmonary arrest. I have actually never seen other causes, extracranial causes, metabolic causes such as hypoglycemia, metabolic causes or hypoglycemia or carbon monoxide poisoning. Just a little note on what can mimic brain death. It's the following conditions. I just want to stress here that none of these conditions, none, causes a complete loss of brainstem reflexes and apnea. They may have some loss of brainstem reflexes, but they will not have all of these. The only medicine I know that causes this is barbiturates, so thiopental in a barbituric coma. So a locked-in syndrome, you usually have constricted pupils. In the high cervical cord injury also, you do not have any reason to have dilated pupils. So all these conditions may mimic, you just need to know them. Just be aware of them. So how do we diagnose brain death? It's a worldwide consensus that it's a clinical diagnosis. Thank you. And that is, the gold standard are the clinical tests. The clinical tests is the brainstem reflex examination and also the apnea testing, not the ancillary tests. We heavily depend on them because they are an image, but they are not the gold standard. Ancillary means providing support to your diagnosis. There is great variability worldwide regarding the testing. You will see this in the next slide. There are religious and moral objections, and of course, there is local government and policy and law. This was published in 2014. It's the variability of brain death in Europe. And it's not very accurate, to be honest. It's quite long ago, but you can see some countries do not even have law or guidelines, even within the European Union. There is a very large difference in clinical examination or the number of doctors required. We even have large discrimination between Greece and us, for example. Just to know, you have to know what is done in your country or where you are working. In Cyprus, we do have legislation since 1987, and it was changed in 2012. It actually requires 2 doctors to do the tests. We do 2 sets of tests with an interval of 6 hours between them. The specialties that can do the testing are anesthesiologists, neurologists, internal care medicine doctors, intensive care medicine, neurosurgery, cardiology, and pulmonology. The largest bulk of the tests, actually all the tests, are done by intensivists. We do have different specialties in the ICU. After the second apnea test, the person is declared dead. So I don't take him off the ventilator and wait for the heart to stop beating. As I said before, he is declared dead at the moment I do the apnea test. It is not important if he has a heartbeat. It does not matter. And I issue a death certificate or after the DSA. So the minimal criteria that I need before I start the testing is neuroimaging. I need to have signs of herniation or edema. Or if I have an ICP measurement, they have to be high measurements, above 20 for a long period of time. I exclude hypothermia because hypothermia is a condition that can mimic brain death. The person needs to be rewarmed at least for 24 hours before I can do brain death testing. Muscular paralysis, this must be excluded. We don't give that much muscular paralysis in the ICU. What we do give is sedation and analgesia. The medications we use are mostly benzodiazepines and propofol for the sedation and opioids for the analgesia. Now, I have a lot of dispute with my colleagues regarding the toxicology that we need to send. The only medication that mimics brain death in the ICU is, as I said before, barbiturates. So their toxicology does need to be sent. Barbiturates have a very long elimination half-life. Especially in impaired renal and hepatic function, and they can mimic brain death, so their toxicology needs to be sent. The Brits have a red flag for fentanyl infusion, which is an opioid, but if the person has normal renal and hepatic function, you do not need to send toxicology. You can wait 5 times the elimination half-life of the drug. In any doubt, you can send. In Cyprus, it takes a couple of days for the toxicology reports to come out. So you have a brain dead person on your hands for a couple of days more. It's very difficult for the family and for the staff in the ICU. So we need to take care when sending toxicology. I need to exclude hypoxia, hypotension, hypoglycemia. And regarding the electrolytes, I will just refer to sodium. The sodium can affect the brain, as you all know. So it has to be within a range of 125 to 160 millimoles per liter. Other electrolytes we check to be sort of normal are potassium, phosphorus, calcium, and magnesium. These are the main electrolytes. We need a normal acid-base status. We do not check for endocrine derangements unless the person has a past history of thyroid disease, for example, or Addison disease. We observe for at least 6 hours after injury to the brainstem. So we need to wait. And after an anoxic brain injury, we have to wait far longer, at least 24 hours. This is a QR code of a demo from the Neurocritical Society in America. It's regarding brain death testing. You can find videos on YouTube, quite a few videos demonstrating the clinical tests of brain death. The main tests are the brainstem reflexes that I will talk about next, and of course the apnea testing. So you have the pupillary light reflex, the corneal reflex, the oculovestibular reflex, cough, gag, and the grimace. I won't go into the pathways. They all pass through the brainstem. They are all through cranial nerves. You can read it in a textbook. I've read them 1,000 times. I never remember them. So the pupillary reflex, you shine a light on the pupils and you check for ipsi and contralateral pupillary response. They need to be in mid position or dilated, never in constricted pupils, but they can be any shape. If the person does not have eyes, if the person has extensive facial trauma and cannot open their eyes, then you request ancillary testing. But you do the rest of the tests. You do the tests and then you do the ancillary tests. The corneal reflexes, you touch the cornea, which is the white part of the eye, not the colored part of the eye, with a swab, and you check for eyelid movement. Again, in any orbital trauma where you cannot access at least one of the eyes, you request ancillary testing. You do not damage the cornea because the person may go for transplantation, for donation after. The motor response, you apply deep pressure either to the condyles of the temporomandibular joints. I prefer the supraorbital notch, it's a personal preference, bilaterally. This causes extreme pain. If you do it to yourself, you will see. And it causes grimacing of the facial muscles and movement. We don't usually check for peripheral motor response, and I will explain why. Because you have a lot of spinal reflexes, and when you see these spinal reflexes, you think it's a purposeful movement, but in reality, it's not a purposeful movement. It's just a reflex. The Brits, they do not check for peripheral painful stimuli. They only check for the central. Peripheral means from the neck down. Central is only the head. We do it in Cyprus. We check, we apply pain to the sternum, so pressure to the sternum, or pressure to the nail bed of each of the 4 extremities. And we check for any grimacing in the face. These are all spinal reflexes. They can be quite uncomfortable to watch, not only for the staff, but also for the family of the deceased. I have seen hugging, a patient coming up and hugging, seems to be hugging. He is not, he has a spinal reflex, he is brain dead. I have seen the Lazarus sign when the patient had a flexion towards the endotracheal tube. Myoclonus and fasciculations are quite normal, and I have seen head turning where all the staff came to me and said the person is not brain dead, but actually they were. These are all spinal reflexes, and you need quite a bit of experience to calm everyone down and differentiate between these. The oculovestibular reflex is the next. It's extremely painful. Anyone had water in the rear canal, they will know. So you place 50 ml of ice water in the ear canal, and you wait for deviation of the eyes. If there is no deviation of the eyes, then this is a positive test. It checks for the same cranial nerves as the oculocephalic reflex. That's why we do not do the oculocephalic reflex in Cyprus. I will explain it later. Gag and cough. Through a tongue depressor in the posterior pharyngeal wall, we check for a gagging. With suctioning through the endotracheal tube, we check for cough. You cannot do this in high cervical cord injury trauma because of trauma to the phrenic nerve. Here's the doll's eyes or the oculocephalic. We do not do it in Cyprus because you can cause trauma to the cervical spine, and it needs an intact cervical spine. It checks for exactly the same cranial nerves as the oculovestibular. You rotate the head briskly from side to side, and if the eyes do not deviate, then you have a positive test, like a doll. If you ever had a doll and you turned their head, you will see that the eyes stay in place. And lastly, we proceed to the apnea testing. The apnea testing is performed after the brainstem testing. There is no order for the brainstem testing, so a doctor can do any order he or she wants. You can do the corneal reflex and then the motor response, and then you can do it however you want. But the apnea testing needs to be after the brainstem reflexes. This is a prerequisite in doing the tests. What you do is you place the person off the ventilator, and you wait for the carbon dioxide levels to increase. This causes a decrease in the pH of the CSF, and this will stimulate the medulla oblongata and cause breathing in a normal person. In a brain-dead person, this will not take place. You do not perform it in high cervical spine injury because you have trauma to the phrenic nerve anyway, so there's no point in doing it. You need to have some conditions beforehand, not in hypoxic patients. The patient needs to be normotensive, normothermic, normocapnic, and of course not breathe spontaneously on the ventilator. You pre-oxygenate the patient for around 10 minutes at 100%, and you advance the cannula through the endotracheal tube. You give oxygen at a supply of 4 to 6 liters per minute. You expose the patient, and you wait for any breathing, you look for any breathing movements, and you draw gases. A positive test is when the partial pressure of carbon dioxide is above 60 millimeters of mercury or 20 millimeters of mercury above the baseline. So in the COPD patient that has a baseline of 60, it needs to be at least 80. Any desaturation, you have to stop the testing. We have had very good experience with positive pressure on the ventilator with the use of PEEP. You cannot have a false positive test with this, only a false negative, unfortunately. We have used it quite extensively during the COVID pandemic, and we have had good results. There is a theoretical risk of barotrauma or a risk of tracheal rupture, theoretical risk again, and of an increase in intracranial pressure. Lastly, the ancillary tests. Ancillary tests are two types. They test through imaging the blood flow to the brain or the electrophysiology of the brain. The ideal test has no false positive. It is sufficient on its own to establish death. It has no confounders, such as drugs. It is standardized, and it is safe and reliable. There's quite a few. In Cyprus, we only use DSA, digital subtraction angiography, or the 4-vessel angiography. It's the gold standard. As you can see, it's 100% sensitive and specific. And we do the clinical test and then proceed to ancillary testing in the conditions I named before. There's quite a few. There's CTA, MRA, but these are not enough to diagnose death. If you see a DSA, you pass a sheath through the femoral artery, and through there a catheter is passed that goes to the internal carotid artery where contrast material is given. And you check for flow of the anterior, middle, and posterior through the basilar artery. So the front part of the circulation of the brain is through the internal carotid, and the posterior circulation is through the basilar artery. You check for flow to the brain. It requires skill and transport of a very critically ill patient, and it has a risk of thrombosis, bleeding, I didn't name the bleeding, vasospasm, and nephropathy. We don't use any electrophysiological tests in Cyprus, so we don't use EEG or somatosensory, auditory, visually evoked potentials, because they are neither sensitive and actually they're not very specific. They have a lot of confounders that are drugs, and they also have a lot of inter-observer variability. I talked about these actually before. Decompressive craniectomy is a problem, but we still try to do the testing. I won't go into detail why. Patients on ECMO, we have quite a few patients on ECMO in Cyprus nowadays. We did have one brain death person. There are guidelines nowadays for ECMO patients as well, so we could use that. Then you document a new checklist. This is an extensive document by the Faculty of Intensive Care Medicine. We have a shorter version of this, and you declare the person dead. All major religions accept brain death. There are only a few exceptions. Some Muslims, Shinto Japanese, some Japanese Shinto, and I believe some Orthodox Jews. But these represent millions across the globe. And there are some problems in some countries, especially Islamic countries like Egypt and Pakistan. African countries, although they mostly accept brain death as a concept, they lack protocols and they don't do the brain death testing. And I just wanted to name a very developed country. I was quite astounded that in Japan, the land of the rising sun, they do not accept brain death as a concept. The good thing about Japan is that they have done tons of study on brain death patients, and no one has ever awoken. So we have had good studies from Japan. They are doing steps in the right direction, but still they have a long way to go. And Democritus said it. He said the patient, the mind that is asleep seems to be dead. And he was right. He said it in another context, of course, but the sleeping mind is like a dead mind, and we see that all the time in brain dead patients. Thank you so much.
Loizu, first I have to thank you for your kind invitation and your sensitivity about the whole subject. My English is not so good as Mrs. Dr. Kastoris before. I hope that I will not trouble you very much. I hope you understand me. As Mrs. Loizu said, I'm the transplant coordinator in Nicosia General Hospital for a long time, and I've been having the team of ICU doctors with me. It's always a very good support to me. So starting, it's to say that, do you know that every 27 minutes a transplant operation is performed somewhere in the world? But every 2.5 hours, a person is dying while he's been in the waiting list, awaiting for a deceased donor that would have saved his life. It's important to know that organ transplantation is considered to be one of the greatest advances of medicine. Transplantation is the process of moving cells, tissues, or organs from one side or from one person to another for the purpose of replacing or repairing damaged or diseased organs and tissues. It saves thousands of lives every year. The particularity of transplants is due to the fact that their development and dissemination does not only depend on the scientific and technological advances, but it mainly depends on the awareness and participation of the social actors and the whole society. The most important factor in the evolution of transplants is the existence or not of suitable and sufficient grafts, the lack of transplant, and the ever-increasing number of patients in need of transplants. Unfortunately, it's constantly expanding and even at the global level. Historically, to say that the first successful kidney transplantation was performed by Joseph Mary in Boston in 1954. Also, the first successful heart transplantation was performed by Christian Bernard in 1967. Many years before, in 1905, an Austrian doctor, Dr. Zerm, has performed successfully the first corneal transplantation. And during the years, many experimental tryings, they tried to do transplantation, but unfortunately they didn't manage until after 1954 and after 60s, the first transplantation. Nowadays, we have transplantation even for the whole face, and it's a great advance, and also the whole arm is being transplanted since 1998. Some of the advances that contributed in the whole advance of transplantation are the discovery of the HLA in 1956. HLA and tissue matching is an important factor for typing that is help to identify when a potential tissue is good and match with the recipient's one. This shows the likelihood of the successful of a transplantation, and it's very important to nowadays. Cyclosporin and other medications, non-immunosuppressants, these are important medicines that they work by weakening the immune system of the body and help the body to accept the new organ. And they accept it as its own organ. Special fluids and machines are being used for the perfusion and irrigation of the donor organs, such as the kidneys, liver, pancreas, and heart, before or immediately after being extracted from the donor. But the most important, as I said, factor is the evolution of transplant, is the existence or not of suitable and sufficient grafts. And this has nothing to do with the science. The European Council reports that 70,000 people are waiting on transplant waiting list, while 18 people die every day waiting for an organ transplant. The need for transplant is constantly growing since it has been recognized that it is the most effective and cost-effective treatment. Who can be a donor? Everybody. And at any age, a willing person to donate is the clue. Types of organ donation. Organ donation refers to the donation of organs for transplantation from a person who is no longer alive, could occur after brain death or after circulatory death. Also, somebody can be a donor while living and can be made while the person is alive in the event that his life and health will not be affected by the process. who can be a donor. Living donors, again, should be over 18 years old. But the Cyprus law says that. There are different ways of, maybe other countries, they have different different ages that accept a donation. But the Cyprus law says that somebody to register as a donor has to be 18 years old. The husband or wife of the recipient can be donor, a relative up to the third degree of relation. That means that my nephew is a third degree relative. Close relation that would be confirmed by the Cyprus Transplant Council is another way of somebody who is not related to the donor to donate if he is willing to. And the second category is the deceased donors. There are people who have been declared brain dead according to the Cyprus law. In Europe and other countries, also patients that lead to diagnosed with circulatory death also can be donors. In Cyprus, the law does not. It's only the brain dead donors that accept. How can be somebody a donor? Of course, to register as a potential organ donor and share the decision with the family. This is the most important thing somebody has to do. Here, this picture, it says about, it's an old one, and it is actually give us the picture of the international donation rate. And here you can see it's Spain and Croatia and Malta and Belgium. These are the leading countries in organ donation. Our Cyprus, unfortunately, you can find it. Oops. It's only here. And if I have a new picture of the same statistics, actually Cyprus would be even lower. And this is what we want, to give information, to actually to make people just investigate and say what he would like to do about organ donation. Which organs can be transplanted? The heart, the lungs, the liver, the pancreas, kidneys, and small intestines are the main organs that can be transplanted. Tissues also can be transplanted, like cornea, skin, tendons, the heart valves, bone, and there are countries that they use all the tissues from a dead person. Who needs now the transplantation? Patients for having been in the end-stage renal failure, they need transplantation, and this is the best option for their as a treatment option. It offers a better quality of life, and patients could have a normal life opportunity. To continue with people having renal failure, it's to say that in Cyprus every year we have more than 150 people ending up to the end-stage renal disease, and they need treatment of hemodialysis or peritoneal dialysis or kidney transplantation. There is a total number, about 1,100 patients having been in the end-stage renal failure. 20 to 30% of these patients could be potentially be on a waiting list. These days we have people only, the transplant list only contains 65 persons. Even this, we are with a very low number. But having only 5 donors per year, imagine that this number is quite big. Now, for people with for the needing, people going to end stage of cardiac or respiratory or hepatic failure, transplantation becomes the only treatment option for them. And the organ is saving their life. And we see some pictures of people in these stages. Does the family now is able to know the identity of the donor? Or is the recipients get to know the donor? The answer is no. And this is done to avoid creation of dependency relationships, either psychological or emotional or financial. We are living in a multicultural place anymore, and people have different customs. So we don't know, and we cannot control this. So even not only us, but also other countries, they have the same, that it's not allowed to give the names of the donors to the families of the recipients. And this is to keep anonymity throughout the process. Organ donation is offered without any compensation, and it is a gift of life to the fellow human being. Organ donation is considered one of the most important acts of volunteering. Altruism and generosity and solidarity and love are the only feelings that motivate someone who, while experiencing the saddest situation, the death of a loved one, overcomes it and bridges life with the death by donating the organs of his loved one. Now some things about the legislation of Cyprus. If there is a living will expressed by the potential cadaver donor for the removal of his organs for the purpose of transplantation, as documented in the National Registry of Potential Donors, this cannot be revoked by any of his named representatives. This is written in the law. Also, the law says that if the potential donor had not expressed his consent or refusal for removal of his organ, the process of organ donation may be carried out if the legal representative consents to it. Steps now in the organ donation process. We have a critically ill patient in the ICU with severe brain injury and severe damage that lead to brain death, and the diagnosis of brain death is done. Then there is, the doctors inform the transplant coordinator, and then we call the first degree relative, the family, the closest person to the dead potential donor. And we check the potential donor registry to see if he's already have been made his will and consent for organ donation, or we have to take a consent by the family. During this time, there is evaluation of suitability of organs. There is still intensive care and management of the potential donor, and coordination of organ removal if the consent has been obtained. Some colleagues, other than us, they find the suitable recipients based on medical criteria. We don't have to do with this, but it's people that is being involved in the whole process. And we have the transplantation, and during all this period, we have the family informed about all the process, what they would like to know. We are in there with them, and we support and give all the information they want to know. Brain death has already Dr. Kastoris explained to us. I will not stay to this. It's just to say just we need two specialist doctors to be present in order to make the brain death diagnosis. The tests are repeated 2 times, and after the second brain death test, the death certificate is given to the family. Now transferring the bad news. The transmission of bad news is done by the doctor who participated usually in the diagnosis of brain death, and we are, at this time, we can be with him. This, to say, is triggering a complex of emotional reactions to anybody who's hearing the bad news. Refusal, distrust, negotiation, depression, and finally acceptance are all the situations and the conditions that happen almost to everybody that is been in this situation. During the family meeting, we want to update on the declared will of the deceased potential donor. There is a verification of his wish in case he did not register while he was alive, and ascertaining the wishes of the family. In Cyprus, just to continue, we say that a kidney transplant program is started since 1986 at the Paraskevaidio Transplant Center. Since 2011, the transplantations are performed at the Transplant Center of Nicosia General Hospital. But what we have to do now? We have to act today. This is the form that somebody could fill if he's full with knowledge, if he knows what to do. If he wants to become an organ donor, he has to search and find this form. We have to act while we're alive. We should be informed. We should be we have to solve any questions and doubts we have. And let's think about what are the benefits of transplantation and who could be at this position, and make our decision on this very important matter. To register, finally, if we like to, if we are convinced that we do the best thing in the National Register of the Potential Organ Donors, knowing that if we find ourselves in these conditions, severe brain injury that resulted in brain death, our organs will give life to someone of our fellow human beings. To communicate our desire to our loved ones is very important. It's not just to us to make a registration, but it's important to talk with our families and our relative, the family, which essentially consent to a decision that it was ours. This is how somebody can make his registration another way, just getting in the web page of the Ministry of Health, and here there is a small, heart. Now somebody can search, and it is a bit lower because of many things have been added in the list. But if he press this, the heart can see the form and can fill it. As I said before, the biggest obstacle of transplantation is the limited number of donors and the lack of organs. Without suitable and sufficient organs and grafts, transplantation is not possible. Transplantation is the result of a teamwork. Each of us could contribute and be a part of the chain of life of transplantation. Because this is the result, somebody who needs a transplant, this is the previous situation. the first, after transplantation, and after some years of transplantation. If we like this, I think we could proceed. And a small film, if I just touch. Okay. It's from a country outside. It's not a Cyprus film, but it's interesting to see. It is done by the Sri Lanka donation department.
තමයි කොරගහන මිනිස්සෙක් දැකලා තව මිනිස්සෙක් අහනවා ඇයි ඔය කොරගහන්නේ කියලා. එතකොට කොරගහගේ මිනිස්සයා කියනවා ඒ මම මේ තතේ නපවරුවක් හින්දා කියලා.
Not very fun, but the boy loves.
නෑ S2